Hi, everyone. I want to briefly talk about the cardiology. To understand cardiology anatomy, the most important first step is knowing how the heart sits in the body. Imagine a person sitting in a reclining chair, slightly turned to the left. The arms represent the atria and the feet represent the ventricles, with the atria always smaller than the ventricles. The right arm is the right atrium, the left hand is the left atrium, the right foot is the right ventricle, and the left foot is the left ventricle. With this image, it becomes easy to remember that the right ventricle lies more anteriorly, while the left atrium lies more posteriorly. This simple mental picture gives a clear perspective of heart anatomy. The heart is oriented obliquely within the thorax. As I mentioned, again, the right ventricle is the most anterior chamber, positioned immediately behind the sternum. The left atrium is the most posterior chamber, lying closest to the esophagus and vertebral column. The left ventricle forms the apex of the heart and contributes most of the left cardiac border. Always consider this fact that the left ventricle is much larger and thicker than the right ventricle. This orientation explains why anterior chest trauma most often involves the right ventricle, and why posterior structures are affected by left atrial enlargement. Understanding which chamber lies anterior versus posterior is essential for interpreting imaging, physical findings, and anatomic relationships. Systemic venous blood enters the heart through the right atrium, which receives blood from the superior vena cava and inferior vena cava. The superior vena cava drains venous blood from the head, neck, upper extremities, and upper thorax. The inferior vena cava drains venous blood from the abdomen, pelvis, and lower extremities. Importantly, there are no valves between the superior vena cava, inferior vena cava, and the right atrium. Because of this, elevations in right atrial pressure are transmitted directly back into the venous system, leading to venous congestion. This explains findings such as distended neck veins from superior vena cava congestion and a dilated inferior vena cava on ultrasound in right-sided cardiac dysfunction. Blood flows from the right atrium across the tricuspid valve into the right ventricle, then through the pulmonic valve into the pulmonary artery. After pulmonary circulation, oxygenated blood returns via the pulmonary veins to the left atrium, crosses the mitral valve into the left ventricle, and is ejected through the aortic valve into the aorta. The tricuspid and mitral valves are atrioventricular valves controlling inflow into ventricles, while the pulmonic and aortic valves are semilunar valves controlling ventricular outflow. On the right of this slide, you can see a schematic diagram of the circulation circuit in the body. And this an animation of the heart showing both ventricular section and the valves. The aorta functions as the main arterial highway leaving the left ventricle. Very early after the aorta emerges from the heart, at the level of the aortic root, the coronary arteries originate. The first exit on the right side of the aorta is the right coronary artery. This is shown as RCA in this picture. The first exit on the left side of the aorta is the left main coronary artery, shown as LCA in this picture. This early origin ensures direct perfusion of the myocardium from high-pressure aortic blood. The right coronary artery travels along the right atrioventricular groove on the surface of the heart. The left main coronary artery is short and divides into two branches. The left circumflex artery courses horizontally along the left atrioventricular groove, supplying the lateral wall of the left ventricle. The left anterior descending artery, or LAD, travels vertically down the anterior surface of the heart within the anterior interventricular groove, extending from the base toward the apex. This straight anterior course makes the LAD the most visible coronary artery when viewing the heart from the front or opening it surgically. The LAD supplies a large portion of the anterior ventricular wall and the interventricular septum, explaining why obstruction of this vessel has major consequences. A key functional principle to remember is that coronary perfusion occurs primarily during diastole when myocardial relaxation allows blood to flow through the coronary vessels. Electrical activity in the heart follows a defined anatomic pathway. The impulse originates in the sinoatrial node, which is located in the right atrial wall. Atrial depolarization spreads toward the atrioventricular node, which is located in the interatrial septum. The atrioventricular node provides a physiologic delay that allows ventricular filling before contraction. From the atrioventricular node, the impulse travels through the His bundle, located in the interventricular septum, then into the right and left bundle branches, and finally into the Purkinje fibers, which rapidly distribute the impulse throughout the ventricular myocardium. This organized conduction pathway ensures coordinated ventricular contraction. Disruption at any level of this system produces characteristic conduction abnormalities that correlate directly with the anatomic location of injury. This is another picture showing the movement of electrical pulse from SA to AV in all parts of the heart. Now that I explained the anatomy a little, let me talk about the coronary dominance. Coronary dominance is defined by which artery gives rise to the posterior descending artery, PDA. It is not determined by vessel size, but by anatomical origin of the PDA. In most individuals, the right coronary artery gives rise to the PDA, making the circulation right dominant. In a smaller percentage of individuals, the PDA originates from the left circumflex artery, resulting in left dominance. The PDA supplies the inferior wall of the left ventricle and the inferior portion of the interventricular septum. Therefore, dominance affects which coronary artery is responsible for inferior wall perfusion. An important physiological principle is that coronary perfusion occurs primarily during diastole. During systole, contraction of ventricular myocardium compresses intramyocardial vessels, reducing blood flow. When the ventricle relaxes in diastole, coronary blood flow increases. This is especially significant for the left ventricle, where wall tension is higher. This relationship between anatomy and timing explains why tachycardia can reduce coronary perfusion. Shortened diastole means reduced myocardial blood flow. The myocardium does not drain into the vena cava directly. Instead, venous blood from the heart muscle collects into the cardiac veins, which converge into the coronary sinus. The coronary sinus is located on the posterior surface of the heart and drains directly into the right atrium. This creates a complete circuit: systemic veins to right atrium, pulmonary veins to left atrium, coronary veins to coronary sinus to right atrium. Understanding this separation between systemic venous return and coronary venous return clarifies why coronary circulation is anatomically distinct from the rest of systemic circulation. The right ventricle has a thinner wall and is adapted for low-pressure pulmonary circulation. Its primary function is volume transfer rather than high-pressure generation. The left ventricle has a thick muscular wall and generates high pressure to overcome systemic vascular resistance. The increased wall thickness reflects the higher afterload faced by the left ventricle. Because of this difference, pathological pressure overload conditions predominantly affect the left ventricle first, whereas volume overload states may affect chambers differently depending on the lesion. This structural asymmetry between ventricles is fundamental to understanding hemodynamics later. The coronary arteries follow predictable surface landmarks. The right coronary artery travels in the right atrioventricular groove, which separates the right atrium from the right ventricle. The left circumflex artery travels in the left atrioventricular groove, separating the left atrium from the left ventricle. The left anterior descending artery travels in the anterior interventricular groove, which separates the right and left ventricles on the anterior surface. These grooves act as anatomical highways guiding coronary arteries along predictable paths. If the heart is viewed from the front, the LAD descending vertically toward the apex is the most visually prominent vessel. The LAD supplies a large portion of the anterior wall and much of the interventricular septum. Because of this broad territory, obstruction of the LAD produces extensive myocardial injury. The right coronary artery in most individuals supplies the inferior wall and often contributes to blood supply of the atrioventricular node. The left circumflex artery primarily supplies the lateral wall. Thus, anterior, inferior, and lateral wall injuries correlate directly with LARCA and LCX respectively. This anatomical mapping allows immediate localization of ischemic territories. And this is the cardiac anatomy summary. The heart is organized as follows. The right atrium receives systemic venous blood from the superior and inferior vena cavae without intervening valves. Blood flows to the right ventricle and then to the pulmonary circulation. Oxygenated blood returns to the left atrium, flows to the left ventricle, and is ejected into the aorta. The aorta gives rise immediately to the right and left coronary arteries at the aortic root. The right coronary artery travels in the right atrioventricular groove. The left main divides into the left circumflex and the left anterior descending artery. The LAD descends along the anterior interventricular groove toward the apex. The conduction system begins in the right atrium at the sinoatrial node, passes through the atrioventricular node, then through the His bundle and bundle branches within the interventricular septum. This architecture integrates structure, blood supply, and electrical activation into one coordinated system.